We shall move forward now with another presentation from the Sunita Project Research Team on training programs and evaluation. What did we learn? And I'd like to call upon Dr. Daniel Monday. Dr. Dan has been trained in anesthesia, family medicine, and palliative medicine. He first worked in Nepal as an anesthetist from 1988 to 1991. His research interests include the interface between palliative and primary care. He's honorary senior clinical lecturer in Usher Institute, University of Edinburgh. His second period working in Nepal has been from 2013 till date. Thank you.
Okay, thank you very much for the welcome. And this presentation builds on our learning from the exploratory research that you've just heard about. And I want to give a little bit more of the background to the Sunita project and the model that we've been implementing, and then talk a little bit about how we evaluated it, and then other members of the team will come and talk about the results of the evaluation. So the 2017 National Strategy for Palliative Care commits to primary palliative care in rural areas and specifies how this can be achieved. It suggests that one generalist doctor and one nurse should have some training in palliative care, and their role should not just be face-to-face clinical, but also supporting community staff. All other staff should have basic palliative care training, and also palliative care training should be given to staff in primary care centres and health posts. And also it suggests that mid-level workers, that's health assistants, community medical assistants or nurses, should also be given special training in palliative care and being able to visit people in their communities to provide care and support to them and their families. And then it also highlights the important role of female community health volunteers. We've already heard about them from the presentation earlier on. And they should receive basic training to support families and also to form a link between mid-level workers, between the mid-level workers in the health posts and the families. So the rural model for palliative care developed by Sunita takes a health system strengthening approach. And as we know, getting care to patients is a challenge, as we've been hearing. Patients are often not able to move from their homes. And the model focuses not just on the health aspects in red on the left, but also the community aspects in blue there on the, on health aspects on the right and community aspects in blue on the left. And then the link between these two, of course, is the female community health volunteers. So this is our base at Green Pastures Hospital, the Palliative Care and Chronic Diseases Unit, which combines clinical care, education and research, and from which we're running the programme. We do a blend of face-to-face and distance learning. The two-day palliative care training, which we call toolkit training, is delivered to health post and rural hospital staff together, encouraging them to form a network or community of practice. We use two tools for the palliative care toolkit. The palliative care toolkit was translated before the Sunita project started. And we also translated the SPICT, which again we've heard of, the Supportive and Palliative Care Indicators tool for low-income settings, for identifying people with needs. This has also been translated into Nepali for the mid-level workers particularly, and is been incorporated within the toolkit, the Palliative Care Toolkit. So our training is in part didactic, classroom-based, but this is kept to minimum, and mostly is case-based, interactive through group work between the participants. And then moving on, for the rural hospitals, we train doctors, again using a very clinical an interactive approach. We train them for 10 days, both at Green Pastures and also in a rural site. And then the mid-level workers, so say they could be nurses or health assistants, get extra training, who get extra training as identified by the strategy. We train them at Green Pastures Hospital over 6 weeks and then place them in one of our partner hospitals where they do hospital assessments of patients and support, community assessments, and also lead community education. And finally, we have echo sessions, distance learning. That's every week for the nurses or mid-level workers and every month for the doctors. And our model is based on the 3 core skills for primary palliative care: identifying patients who need palliative care, a holistic assessment, and then planning care with the patient and the family. So if a patient is admitted to the ward, they'll be identified on the ward round used in the SPICT LIS. Our SUNITA mid-level workers or nurses will go on the ward round each day so that they can identify those patients with the doctor. And we have the SPICT LIS laminated, and it becomes part of a notes trolley for quick access. Once identified, the doctor should consider what is the best available treatment for that patient. Now, we really stress that palliative care is not about stopping treatment. It's about identifying the best available treatment for that patient in their context. The nurses then make a holistic assessment with the patient and the family and agree a problem list. And as I say, the assessment involves patient and family, and to get a very clear idea of what the challenges are for them. The nurses and the doctor can now meet and discuss a plan which is agreed then with the family and with the patient and the carer. And then the process continues if the plan needs to be changed as the patient's condition changes. Then we deliver 2 days training for female community health volunteers, and the FCHVs in turn work with the 2 SUNITA mid-level workers in delivering an awareness program to community groups, particularly mothers groups, who the FCHVs are already working with. Building programs have also been run in schools, and they use an animated video to aid in the learning. So we've been doing the SUNITA project for 3 years now. It's probably about 18 months, 2 years, 18 months that we've been really being able to implement the model. And so we started thinking about evaluation this time last year. And it's a very complex, multifaceted, and so we needed to think very carefully about how we went about the evaluation. And it's basically got 2 parts. We're doing a research study, a survey of patients in hospitals and some in the community using for early impact and feasibility. And also doing interviews with the patients, carers, and key informants. And secondly, evaluation we've been providing using a variety of methods. And we'll be hearing this about the results from these evaluation and the research from my colleagues. And I'm going to hand over to Purnima. Thank you.
Thank you, Dr. Dan. Good afternoon, everybody. You are already heard from the Dr. Dan how the SUNTA project provided the toolkit training to the hospital staff and health workers at different level. In this presentation, I will be discussing our evaluation of the health workers who have received that palliative care training. These are the objectives of our study: to assess the knowledge and understanding of palliative care among the hospital staff and health post workers, to explore their self-assessed competency for palliative care practice, to understand the importance of SUNITA project model in their practice, and to identify the barriers and facilitators that influence healthcare workers' ability to provide the palliative care. We conducted a mixed method study, quantitative and the qualitative. Quantitative data were collected through online survey by using the SurveyMonkey platform, whereas for qualitative in-depth interviews were. The online survey was sent out to all 180 participants who had received toolkit training. 122 of them filled the questionnaire. 109 filled it in full, giving a 61% response rate. In contrast, the qualitative questionnaire was just carried out in 4 municipalities. Moving towards the result, among 109 participants, 77 were from the health workers and 32 were from the rural hospitals. This slide presents the impact of training in 4 key areas: usefulness, coverage, quality, and satisfaction with the palliative care training. Majority of the health workers participants rated it between 3 and 4, indicating that training has made a significant impact, improving the capacity of health workers to deliver the compassionate and effective palliative care. Before the training, many participants had no knowledge of palliative care. There was a common belief that chronic illness could not be managed and pain cannot be managed. However, after the training, 90% of participants reported a moderate or a great increase in their knowledge and understanding of palliative care. Most of the participants, they applied the palliative care principles in their practice. Now they reported that they provide the holistic care, actively listen to understand patients, and offer the counseling for support and guidance. Most of the health workers were confident to provide the palliative care after the training. Health workers report that they take the time to listen to patients properly, and they are doing the basic care like home visit, counseling, prevention of bed sores, if required, dressing at home. According to the online survey, the majority of health workers reported that they use the Speak Alliance to identify the patients with palliative care needs. On the slide, you will see some quotes from a health workers and a doctor. However, we did not find such a high level of Speak Alliance used in the qualitative survey. Similarly, most of the health workers also use palliative care toolkit. So in the online survey, we asked the health workers on identifying the people with palliative care needs. 87% of the health workers reported that they see someone with palliative care needs at least once a month. Over a quarter of health workers said they see palliative care patients every day. This bar chart also shows that there is a small group of palliative care workers who are not identifying the patient in need of palliative care. From the online survey, 38% of the health workers reported they had actively engaged with the Sunita Project rural palliative care workers. In the qualitative interviews, we found evidence that those health workers who engaged with the Sunita staff were also more likely to do the frequent home visit for patients. A significant majority of the health workers reported confidence in being able to integrate the palliative care with other services they deliver. In the online survey, we also asked what are the barriers to deliver the palliative care in their rural setting, and our findings are summarized here. For example, when asked whether the lack of support from the colleague was a barrier to care, about half of the health workers said no, and only a few said it was a significant barrier. Health workers also reported cultural, social taboos and access to medication and equipment are the most significant barrier while providing the palliative care. On this slide, we summarize the challenges to provide the palliative care that were raised during the qualitative interviews. Patients refer to insufficient human resources, inadequate equipment, and the difficulty that patients with palliative care need experience when they have to visit the health facilities due to their age, terrain, and lack of transportation. During the qualitative interviews, we received some recommendations from the health workers. They are as follows. We should have a designated palliative care lead at the rural hospitals, provide the training for all health workers, establish the systematic recording and reporting, develop a networking group, and work closely with the local government to provide the palliative care. These are the conclusion of our study. Rural health workers report that training has increased their knowledge and understanding of the palliative care. Their skills and confidence have increased. They are keen to apply the palliative care knowledge and skill to their practice. And some reports, some challenges include lack of staff and equipment. People often not able to reach the health facilities. Now, to take us further into the role and contribution of female community health volunteer, I would like to call Ms. Soita. Thank you. Thank you, Ms. Purnima. Good afternoon, everybody. Today, I will be sharing insight from evaluation of palliative care training for female community health volunteers, FCHVs. Let me quickly introduce the female community health volunteers, FCHVs in Nepal. FCHVs are local women who are the first point of contact for providing basic health education and services in communities in Nepal. Let's move forward into the details of palliative care training for FCHVs and the key findings from this evaluation. As part of evaluating the Sunita project, we aim to assess how well the palliative care training provided to female community health volunteers, FCHVs, has impacted their ability to provide quality care. These are the guiding evaluation questions. Has the Sunita project training and support enabled FCHVs to provide palliative care in their communities? How do participants identify and refer patients with palliative care needs? How have participants practiced their palliative care knowledge and skills while caring for people with palliative care need and their families? Talking about the FCHV's training data, 258 FCHVs attended first training and 313 attended second training, where 253 attended both trainings in Lomjung and Rukum West. 29 FCHVs was proposally selected for FCD, ensuring the FCHVs has attended the both trainings. The focused discussion were conducted using semi-structured questions under the consent of participant. The data was recorded electronically along with the field notes. The data was then transcribed, translated, and analyzed during thematic analysis. Moving towards the finding from FZD, I would like to encourage you to read the quotes from FCSBs, which speak volumes about the impact of the training they received. We can see that they have learned the therapeutic value of communication skills like listening more, understanding them more, speaking less, and sometimes just sitting with the patient and listening to them can bring relief. FCSGs are empowering families in the community by sharing the knowledge and skill they gained from the training and helping caregivers provide better support to the patient. Have a look at the second quote, particularly. Here's a situation where a bedridden patient had developed a bed sore. As the FCSBs had learned how to manage this situation, they was then able to teach the caregivers, and the wound is now healing. Following the Sunita training, the FCSBs had recognized the extreme importance of supporting caregivers who can easily become tired and frustrated while caring for the patient. The reputation and trust of FCSBs in their community had been improved by the practical training that they had received from Sunita. Talking about the key challenges for FCSBs during the focus group, FCSBs expressed dissatisfaction about their aspect of their work, including the fact that they lose money when they attend midday training and programs. Communities often expect more from FCSBs than they can provide. It also highlights the gap between the FCSBs for what the FCSBs are trained for and what communities expect from them. Lack of roads and walking through the forest whole day, managing their own food is a significant barrier to the work of FCSBs and the service delivery generally. Here are some requests and recommendations that came out of our discussion with FCSBs. This relates to raising community awareness, provision of basic medicine, and a realistic financial remuneration for the FCSB's work. The FCSBs also asked for refresher training in the area of palliative care and working jointly with other health workers. So in conclusion from the discussion we had with FCSBs, I'd like to make the following points. FCSBs plays an important role in supporting patients and families in the community. They display dedication and a wish to provide care. Training has enabled them to communicate, provide practical support and advice, and has increased their confidence. They also face major challenges like limited resources, inadequate allowances to cover their expenses, unrealistic community expectation, and they are keen for further training and better organized support. Thank you. I would like to call Ms. Sunita for the presentation.
Thank you, Soita. Good afternoon, everyone. I am here to present a survey of patients admitted to 3 hospitals implementing the Sunita model. Data collection finished just 2 weeks ago. So I am here to present very early preliminary findings with you all. We wanted to see the early impact of palliative care delivered to patients in the Sunita project partner hospitals. We specifically wanted to look at patients admitted with palliative care needs over the 2-month of period to know their experiences during hospital stays, and also to assess effectiveness of admission using Nepali palliative care outcome scale, also to look at the types of support that patients needing palliative care and their families are receiving from rural health workers. The study was carried out in 2 rural districts of Nepal in 3 rural hospitals. We were looking at the patients who had already been identified as having palliative care needs by clinicians using SpeakTLIS tool. We studied those patients using both quantitative and qualitative methods over the 2-month of period. We assess our patients using Nepali Palliative Care Outcome Scale, which is translated and adopted version of International PAUSE tool, which is specifically designed to measure patients and caregivers' need. There are 19 questions in the tool, all scored on a 5-point scale. And the questions address patients' physical need, psychosocial and spiritual need, as well as family anxiety and burden. We collected data of patients admitted in 3 rural hospitals over the 2-month of period between on admission and discharge. Then after a month, we did phone follow-up to all those patients, and we also did in-depth interviews with hospital patients and community patients. Across the 2 districts, we surveyed 80 patients in 3 rural hospitals, and we explored more in details with in-depth interviews. Coming to the patients' demographic results, over the 2/3 of patients were female with the median age of 70, and among them, more than half of the patients belonged to Brahmin Kshetri ethnic group, and other patients divided into different ethnic group according to the Nepal government ethnic categories. We were surprised to see that over 4/5 of the patients have had no education at all, with very poor literacy rate. This chart shows the total number of patients admitted in 3 rural hospitals during over the 2-month of study. In Chorzari, 12% of those patients had palliative care need as determined by SpeakTLIS, and smaller percentages were seen in Besi Sahar and Rainas. COPD was far and away the most common diagnosis in patients with palliative care needs. The overall length of hospital stay is 5.5, ranging from 1 to 12 in 3 rural hospitals. And this graph shows the average length of patient stays during over the 2 months in 3 rural hospitals. The next few slides look at the data obtained using ANPOS tool. This graph shows the change in mean score of ANPOS tool in Chorzari and Lamjung between on admission and discharge. The next few graphs look at the NPS score of our 80 patients at admission and discharge. You will see that there is a significant drop in physical symptoms and a smaller reduction in emotional, psychosocial, and spiritual needs of patient. However, we didn't see much changes in family anxiety and burden. The next two slides show change in our patient score physical symptoms during admission. There was a substantial improvement in pain and minimal improvement in mobility. We can see the good improvement in shortness of breath and some improvement in weakness. The slide shows the outcome of patient admission. One of the 80 patients died in hospital and the other 79 survived to be discharged home or referred to another health center. After a month, we carried out phone follow-up on our patients. We were not able to reach 19 patients, but a total of 51 are alive and a total of 10 had now died. In Nepal, there is a government health insurance scheme, and 76% of our admitted patients were enrolled in it. And of those, 97 said that the insurance had been helpful in reducing their financial burden. I would now like to turn to our qualitative data. We have early emerging themes, which I will show on the next few slides, along with relevant quotes from patients. As might be expected, hospital patients express emotional and psychosocial needs. A majority of our patients were old and frail, living alone, and they were keen for extended hospital stays. Turning to the caregivers of hospitalized and community patients, they expressed the fact that they were experiencing physical and emotional exhaustion. And in community, patients reported that the palliative care support they had received easing their emotional distress. I would now like to conclude that 10% of admission to the 3 rural hospitals have palliative care needs. COPD was the most common among admitted patients, and we have seen improvement on patient physical symptoms more than psychosocial and spiritual needs. Patients and caregivers feel safe and supported in hospital and preferring to stay more than home. In community, we found that patients are benefiting from home visits done by our palliative care rural health workers. And over the next few months, we will be exploring these data more, triangulating with results from other part of the evaluation of Sunita. Now, I would like to call Mr. Vardan Karki to enlighten findings from local key stakeholders. Thank you.
Good afternoon, everybody. My name is Vardan Karki, and today I'll be sharing about the evaluation of Sunita project. And the title of my presentation is Engaging Local Stakeholders for Sustainable Palliative Care. The main objective of conducting this evaluation was to gather in-depth insight from local leaders and health officials about the implementation and impact of Sunita project, rural palliative care model, and similarly to identify challenges and need in rural palliative care and to collect the feedbacks and suggestions from stakeholders on how to improve the project activities and ensure sustainability. So we conducted semi-structured interviews in our project sites, basically in Besi Sahar, Rainas and Sundar Bazar in Lamjung, and Chaurzari in Brukum West. We engaged key stakeholders, including mayors, health section chiefs, ward chairperson, hospital administrator, and medical directors to understand their perspective on palliative care in their communities. So, from the analysis of our data, we basically find out how the project has been helping to develop palliative care in rural Nepal. Similarly, we will also look at the impact that the project has brought in our working areas, and as well as identify the challenges that are still persistent while delivering palliative care. So let's first talk about how the model has helped to develop the palliative care in rural areas. The first one is the integration of clinical and community services. This has helped to bridge the gap between hospitals, health posts, and community-based cares, which are provided by the female community health volunteers. Before the training, health workers rarely conducted community visits. Now they visit patients, understand their conditions, and provide much needed care and counseling. As one of the health section chiefs shared that this has been transformative for the marginalized and financially disadvantaged patients. Another critical aspect is the empowerment of female community health volunteers. FCSBs now play a crucial role in identifying patients and providing basic palliative care. As one of the health coordinator noted, this has helped to extend services to those in need. Similarly, we have educated the students about the palliative care in various schools in our working areas, and we believe this has created a ripple effect in the communities by educating the youths about the palliative care. One of the most impactful initiatives has been the home-based care. Many patients in rural areas are bedridden and cannot visit hospitals. Through joint visits by health workers, FCSBs, and health workers and FCSBs, patients receive personalized care and emotional support. As one of the mayor of our working area has pointed out that the best way to provide services is through the home visit. And the project has also established research and referral hub at Green Pastures Hospital, PCCD unit. And GPS PCCD units serve as a referral center for research hub for improving care. And one of the medical directors from our partner hospitals has pointed out that how the telemedicine and eco programs help them to connect with the health workers, with the specialists. Now, let's talk about what the impact our rural model has made. The first one, it has increased the awareness and acceptance of palliative care in rural areas, the topic which wasn't widely understood by the local stakeholder as well as the health workers. But now, from our efforts, from the efforts of the Sunita project, it has now widely understood by the local government, health workers, and the communities. Similarly, another impact that we have is the capacity building of doctors, mid-level health workers, and FCHBs. Training programs have improved the skills of doctors, mid-level health workers, and FCSBs. Health workers can now identify and manage palliative care cases more effectively. As we can see that one of the hospital administrator has noted that I noticed an increased confidence of our doctor and nurses after this palliative care training. Similarly, one of the health section chief has pointed out that after the training, the health workers now confidently identify and manage palliative care cases even at the ward level. The another impact we believe we have is the increased access to palliative care and improved patient care. The patients who previously couldn't reach hospital due to geographical constraints now receive care through health and home visits. This has significantly improved the quality of the life and the patients. Similarly, as we know, the project is for certain duration, so we also work for the sustainability, and the models ensure the sustainability by integrating palliative care into existing health system and community structures. As one of the mayor in our study area pointed out that after the project ends, it is our responsibility to continue the work. This highlights that even after the project concludes, the local government is keen to develop the palliative care model in their working areas. So through this project, what we have learned is, number one is community engagement is the key. And the second one is training programs are effective and the local government support is crucial for sustainability. Because the involvement of FCSBs, mothers groups, schools and community and health workers has been crucial in identifying patients and providing palliative care case at the community level. Similarly, the training programs has been effective to build the capacity of the health workers and FCHBs. Similarly, the municipalities are also now willing to invest the budget for palliative care. In spite of so many achievements and lessons learned, there are still some challenges that are persistent in the rural level. The one is that, as our previous speakers have also already discussed, the limited resources in the rural areas. Rural hospitals lack dedicated staff, separate wards, and essential medicines like morphine. Many rural hospitals and some facilities only rely on basic pain management drugs such as diclofenac. The another major challenge is the low patient flow for palliative care cases in the rural hospital. This is due to the cultural barriers, family reluctance, limited awareness that leads to the fewer patients seeking for palliative care, financial constraint, and the another is that many patients in the remote areas, they prefer to go for the treatment in urban centers rather than visiting their local hospitals. As we can see, one of the health administrator has noted that we lack proper setup and patient-friendly environment for palliative care. Similarly, the another challenge is geographical and transport barriers. The patient in remote areas struggle to access to hospitals and health facilities, and this also highlights the need for home-based care in palliative care. So, in summary, we can conclude that the Sunita project has made significant progress in strengthening palliative care in rural Nepal. However, some of the challenges still remain, such as limited awareness, geographical barriers, family reluctance, and resource constraints. So for the path to the sustainability, what we can do is by advocacy and training and collaborations with government and proper resource mobilizations. So it's time to act for us all now. All the stakeholders, municipalities, and healthcare providers must prioritize palliative care to ensure dignity and care for all in need. So to sustain palliative care, what we propose is, number one is improving access to medicines and equipments. Another one is expanding home-based care programs. Another one is developing incentive schemes for health workers to support them, maybe like minimum amount to provide travel cost while they visit in the ward levels. Similarly, by expanding trainings for health workers and FCSBs, we have provided trainings for certain number of health workers and FCSBs. I think this needs to be expanded at higher level to include more health workers and community volunteers. Similarly, we also need to provide economic and social support for the families and work closely with the local governments to develop sustainability plans. As one of the health section chief has said, we will allocate the budget to purchase medicines and medical supplies, which signifies that local government are also keen to invest on palliative care. Thank you from my side. And at last, I would like to thank all the local stakeholders, health workers, and community health volunteers who has been in the part of our journey. Thank you so much.
Thank you very much, Sunita Research and Training Team. We have few questions and some comments from the virtual platform.
Yeah, thanks very much. We've actually had up to 24 people online and quite a lot of discussion going on. There's one question for you, Dr. Dan. So while you're making your way up to the podium to answer that, I'll just read out some of the very appreciative comments that we've had. This is from half a dozen different people. I'll just summarize them. Excellent to see the positive outcomes of training and the ongoing mid-level worker support. I learned so much. I love the holistic approach to the presenters. Great work done to really help people benefit from palliative care in the community. Well done, everyone involved. Exciting to see the empowerment of female community health volunteers. This is impressive to see the benefits and enthusiasm of everyone involved. Excellent presentations, interesting and helpful insights. Great work. And I think finally, thank you so much for the presentation. It's good to get updates and the research summary. So lots of really positive comments coming in. Now I've got a question for you, Dr. Dan. This is from Catherine Pettus. You talked about the national policy framework for palliative care. Catherine wants to know what was the government involvement or support in that framework?
Okay. Yeah, thank you very much. Yes, so we referred to the National Strategy for Palliative Care, which was developed in 2016 and 17. There was a lot of government support at the time. In fact, the strategy was signed by the health minister, but clearly there's been a lot of reorganization within Nepal. In Nepal, the health services leadership management has moved from to municipality level, and that's happened over the last few years. For instance, you might have wondered why we were talking about district hospitals and then talking about rural hospitals. Well, basically, as far as I'm aware, district hospitals no longer really exist. Each municipality is now getting a hospital. So, and those might not be government institutions, they might be community-based hospitals, which are not for profit, run by the community, but can actually access health insurance. There's been a lot of change over the time. And actually the government are revising a strategy at the present time. And we hope that will be released really quite soon with the updated to the current sort of health services structures in Nepal. And I know that there are people in the union a lot more than me, so I don't know if anyone wants to comment on the government strategies and things. Professor Rajesh or Vishnu, Professor Vishnu. I think.
Thank you, Dan. As Professor Dan said, that the initial draft of the National Strategy of Palliative Care was drafted in 2016-17 and was handed over to the government. But due to some reason, it didn't go ahead. And again, the Ministry of Health requested WHO for the new draft. And with the consultation with all stakeholders, then the previous draft has been refined depending upon the changes in the country, central to peripheral region, and draft has been handed over to the WHO, and from WHO to the curative division of the Ministry of Health, it is underway, and I hope that draft finally will be endorsed again. Thank you.
Thank you very much. If there are more questions, we can take a few more questions. Yes.
Thank you, Dr. Dan and team for this initiative. I am very thankful for the training or toolkit you have developed. And during your training or research or your time in the rural hospitals or in the community, did you find any good component that you could incorporate in the toolkit, what you have planned? Good things about palliative care that may be psychological, cultural, or social or economic component in the community, which is already existed in the Nepali community, which you can incorporate in your training. Thank you.
Okay, I'll answer that as well. Yeah, I mean, I think the whole project, I mean, your question is about what is in the community rather than what is in hospitals. So I think the whole project was about building on what's already there. We know from the WHO, we know that actually, well, we don't need the WHO to tell us, but the WHO have pointed out that the majority of care happens in the community, delivered by families, delivered by the community. And every community has different ways of doing it. And so I think that actually we have experienced, particularly through our community groups, how the community is caring. We've got a lovely example of that tomorrow as we launch a film that we've been doing. But you saw there in the first presentation about the research how people are saying, yes, the family and the communities are helping us, are supporting us, giving us support. I think a lot of the time people don't really know what to do. They're not used to looking after someone with chronic illness. They're keen to do it, but they haven't got the skills to do it. So actually, I think we can build on their keenness, you know, the love that's shown, the compassion that's shown within the communities, and that actually enabling people to care. And I think actually the film tomorrow will give a very good example. It was with just one person how that's happened. That can happen, you know, but we really need to understand how the communities function, you know, what are the strengths and how those can be built on to actually move forward.
Thank you very much, Dr. Dan. Are there any more questions?
Good afternoon. Myself, Dr. Sisir Devkota, Medical Superintendent from Lumjung Hospital. Thank you for a nice presentation. And Sunita project is really doing very well in our Lumjung Hospital. My question about the previous presentation, that one of the presentations shows that the majority of the patient who had physical symptom got improved after this palliative care. And my query is whether the patient is receiving medical care at the same time, whether this care is or not. And one of the presentations shows, although majority of the patients were enrolled in the health insurance program, but they do not seek health behavior, health facilities. The study shows that it is because of the cost. But there are various programs in the hospital social service unit. Although the patient have to pay 10% co-payment system have been implemented in the hospital. If the patient do not have money, we are treating the patient from the social service unit. So that could not be the reason that health insurance program is not the reason that the patient is not going to the hospital. There are the cost of the ambulance might be the cause, but the health none of the patient got. We are not leaving the patient, those who do not have money from these health facilities. Thank you.
Yes, no, thank you for that question. And I think, so it's a little bit difficult to hear in this room when you're standing up here. So, but I think I've got that actually there is a lot of provision for people that's possible, but maybe not accessed through health insurance, but through other things as well. And I think from our exploratory research, people actually aren't often aware of things in the community. And so it's about health education. It's about enabling people to understand what it is they are able to access. But I think also we've again found in through the project, and yeah, it's been a delight to work with your hospital in Lumjung, that actually the doctors really do appreciate the training that we're giving in terms of developing this holistic approach, and that's making a big difference. And so I know that good care is already provided in hospital, and through health insurance, it's reducing the costs. But I think that there's also, you know, the care can be made even better through training of the staff, training of the doctors, and the other staff in order to really provide holistic care. You know, I think for me, I think what I feel that the Sunita project has done is it's proved a concept that actually palliative care can be provided very effectively within rural hospitals. But I think, you know, as in all health systems, it's the same in the UK. We have palliative care in hospitals, but it's not always very well done, and it needs to improve. I think it's the same in Nepal as well. We can actually, through training, through support, and we mentioned the distance learning, over Zoom that we do. Again, that's a good way of actually, in a mountainous country like Nepal, where it's very difficult to get from one place to another, places like Green Pastures Hospital can support through Zoom and through sort of programs like that. So I hope that's answered your question. I might not have heard it all properly. But I don't know if there's anything you want to come back on at all.
Thank you, Dr. Dan. And I have few queries, and all the part I would like to thanks all the speakers and especially the leaders beyond the Sunita projects who really bring this palliative care to the community level in the different part of the country. So I going through maybe some of the data, maybe preliminary, but I just want to know there is lots of difference in palliative care in adult and pediatric, even the city and major tertiary hospitals. Yes, we are training the family community health volunteers and we are going up to the village levels. Did you find any finding regarding pediatric pediatric, just like the required in just like COPD is one of the commonest cause in, but there is others bronchiolitis, childhood asthma, cerebral palsy, neurological disorders, so many other pediatrics diseases which may require long-term care for the palliative care in the community level as a home level. So do you have that type of analysis or maybe what they are finding or your plan to be in the Sunita project so that it can address the need, maybe forgotten people's, maybe children's, maybe even in the disease area in the far in village, maybe in a very remote area, the children even they can getting cured and we are supporting the family community for that intent as well. Thank you.
So we did survey with patients above 18. We didn't include pediatric or below 18 patients.
So maybe I can answer a little bit of that. Well, in our research, we haven't done that, but what we see in the community levels is that the FCHVs, report or identify the patients, especially with cerebral palsy in children. And they ask our community educators who are there in our rural hospitals. And that's how they have been identified and we've been able to reach out to them. But from research point of view, we have not done so far. Thank you. So we will take one more question from the floor and then we have one more question from the virtual platform and then we'll have to go to the comfort break. So one more question from here.
Thank you. Thank you so much. Thank you, Dr. Dan, and all the presenters for wonderful presentations, and so encouraging to see the young crowd taking initiatives and leading the research work. Just one quick follow-up question on the costing. So in one of your presentations, you were talking about 71% enrolled in the health insurance, which sounds to me really encouraging, but the 17% not avoiding the care due to cost. I just wanted to understand whether you were referring to the premium as the cost, or you're talking about any other cost associated with it? Why were the people enrolled in the health insurance not accessing the care? If you could just clarify, that would be helpful. Thank you.
Thank you for the query. As I have shown the verbatim of the caregiver, while being insured, also they are not going to the health services because it is out-of-pocket expenditures which are leading them for underutilization of health insurances. Did I answer?
I think it's particularly transport. That's one of the big issues that they have to spend money on. But also, actually, sometimes they know which hospital they can go to, but they don't really feel that hospital is going to provide them the care that they want to. Now, whether that's true or not, I don't know. But they don't want to spend money going there. They prefer to maybe go to a city, to a tertiary hospital, because they say, well, if we spend money to go there and then we don't get the care we need, we still then have to go to the tertiary place and spend money there. So I think it's very complex. And I think it's something that actually would be good to do some more in-depth studies on. I think we've only just sort of scratched the surface, really. But we are still looking at the data to still trying to understand the sort of health-seeking behavior around that.
One more question for the virtual platform. This is really related to the family. And of course, we've seen the family and the individual at the middle of the Sunita model. And the question, I think, has an in-depth understanding of some communities in Lamjung, is saying that some of these communities are quite extended. The fact it's not just the family, it's other people involved. And are there ways in which that wider community can be involved in palliative care Maybe you've said this already, but perhaps you could just expand on that. And just talking about that, just to say we've had a lot more really encouraging comments from online. Well done to the whole research community engagement teams, really encouraging results. So maybe just answer that one question, and then it's probably time for a break.
Okay, thank you. There was a question from online about how communities get more involved with caring. Yeah, and again, again, I think you'll see a very good example of that in the film which we launch tomorrow. So if the questioner can come back and see that, that would be very good. I think as Adipti said, that actually there is a lot of community support, particularly around giving people loans and sort of crowdfunding as well for getting people care, because even with health insurance, as we've said, care costs can be quite great. Again, I think we need to do more research, and to say we're still looking at our data around this, but more research around understanding care and how we build on that care. I feel, again, I've said, I feel we've proved a concept in my mind, and we're still working on that. But another thing is actually for each area that we've worked in, I think it's thrown out many more questions about how we really support communities to provide palliative care. And I think Professor Rajesh, when he does his talk tomorrow, I think he'll touch on this as well, because I think the Mukwanpur project that's been going now for 10 years has got a lot of experience of working with communities and seeing the way that communities come together and really care in that situation. So I hope I wasn't dodging the question, but that's what I'd say, I think, today.
Thank you. Thank you very much. Thank you, team. Thank you for such rich discussion.